respiration a little elevated. So the patient is breathing faster than usual. Why? Because we know that the patient is having some liquids in the lungs. So patient is a human being, it's not a fish. So having liquids in the alveoli impairs the gas exchange. So it becomes a little more difficult to obtain oxygen, okay, from the lungs if the lungs has liquid. That's why you notice that the patient must compensate this impairment in the gas exchange with increment of the respiratory rate. So this is expected. It is expected. And the O2 saturation receiving oxygen is 94%. So this is not normal, but the patient is stable. This level of saturation of oxygen of the hemoglobin is acceptable with a low rate of oxygen. So this is the information that we have. So now let's go to the side of these four diagnoses, which is the most probable. Anemia, no, the patient has 14 of hemoglobin. We rule out that. Type 2 diabetes mellitus, yes. We suspect the patient is type 2 diabetes mellitus. Heart failure, yes. We know because the test and the other clues that the patient is in heart failure. Urinary tract infection, no. We rule out urinary tract infection because we know that the patient has a normal urine, has not infection. So the diagnosis that we need to choose is between heart failure and type 2 diabetes. Which one is the problem that brings the client? The heart failure or the type 2 diabetes?
The heart failure.
The heart failure, because the
Heart
two type
failure.
diabetes is compensated.
Mm.
How I know that the type 2 diabetes is compensated? Because the A1C is normal
Hemoglobin.
and the glucose is normal. So as a nurse, even if the client has two diagnoses, my common sense says that the one that I need to choose is the one that is demonstrating decompensation. And how I know is decompensated? Because the BNP is elevated and the X-ray is showing cardiomegaly with lung congestion and the... Sail away party Thursday, July. Can you repeat? I couldn't understand. No, it wasn't with me, no? Okay, so I'm sorry, I'm deaf. And if you're talking to me, I didn't understand you. Okay. ¿Cómo se llama? I noticed that tachycardia and, some dyspnea and, impairment of the gas exchange that supports that the problem of the client is heart failure, is not the diabetes mellitus. Okay, so we agree, all of we, that we choose heart failure as the main condition that we need to choose in this client. Okay, so what we do with this client, is this pertinent to elevate the head of the bed?
Yes. Yes.
Of course that yes. It's the first that we need to do in a client that has problem to breathe. In this case, the gas exchange is impaired. So, and the client has fluids in the lungs. So the best is to elevate the head of the bed in what is called the orthopneic position. That is a high Fowler, 90 degrees elevation, preferably with the legs dangling and allowing the patient to support the hands in a solid surface. It will facilitate the use of the accessory muscles of the respiration. Normally, a person breathes only with the diaphragm, but when a person is having, dyspnea, when the patient is having this distress, this failure to obtain oxygen, the person starts using the muscles of the neck, the muscles of the shoulder, the muscles of the arms and the back. Those are called the accessory muscles of the respiration. So it's good to have the patient upright, okay, high Fowler, 90 degrees, and with a surface where to support the hands. Why? Because if you have a solid surface to support the hands, you can more easily use the muscles of the arms and the back and the shoulders that are the accessory muscle of the respiration. This position frequently is called tripod position because one hand, the other hand two, and then the butt in this case, 1, 2, 3, tripod position. Also it's called orthopneic position. Yo no tengo aquí cómo escribir. ¿Qué hago yo para escribir? Ok, me da chance de escribir. Claro, yo estaba usando Zoom en la mañana y por eso podía escribir, pero esto no es Zoom, esto es la basura de Teams. Okay, so the patient should have in this orthogenic position, and this is Nclex frequently tested with pictures, with image, or with words, in which position you put a patient with respiratory distress, and you need to choose between 4 positions that are mentioned with words, orthopneic position. Or could change the question, say high Fowler position, or could be changed the question, say tripod position, that at the end are the same, the positions that facilitate the breathing of people that are having problem of gas exchange and hypoxemia. Okay, and this is the anchors. This is the anchors. If you know as a nurse, your priority. So very good for you that you should choose elevate the head of the bed and not moving that. They move that. Okay, so I move that here because I'm pretty sure it is going to be correct. Teach the client signs and symptoms of hyperglycemia. Is this pertinent? It is adequate. It is logical in this moment when we are dealing with heart failure to be teaching the client about something that is compensated. No, doesn't make sense. So we don't choose that. Encourage intake of low sodium diet. Is this important in a person with heart failure with edema?
Yes.
Yes, it's important. But let's see, there is something more important. Assess fit for sensation. What means that? Why I would need to test the fit of this client to see if the client is feeling normally or not, because the client is diabetic. Yes? But is diabetes the main problem? No. So is a priority for heart failure to check if the person has diabetic neuropathy, polyneuropathy in the legs? No.
No.
It's not a priority. It doesn't mean that it's not important, but I need to choose the two most important. Encourage the client to have a diet rich in iron-rich food. Is the patient having anemia? No. Is the patient having evidence of iron deficiency? No. So it is not important. So the best that I can choose here is encourage a low sodium diet. Makes sense, no? So obviously, the way that have been presented is very easy because definitively the other options are nonsense. Okay, let's see which maybe if you don't make so much noise or you mute your microphone, is going to be more comfortable for all of us. So let's see if what I am going to monitor in this patient. White blood cell count. The patient has an infection? No. The patient have leukopenia? No. Why I need to monitor white blood cell? No, I don't think it's important. Blood pressure. It's important to monitor blood pressure in this patient.
Yes.
Yes, the patient is receiving carvedilol, is receiving furosemide, so the blood pressure is not perfect, so it looks that blood pressure could be an option. Let's continue. Finger stick blood glucose. It's pertinent to monitor that because the patient is diabetic, but diabetes is the most important here. No, we are talking about heart failure. So finger stick blood glucose, which is the same of what you know as AccuCheck, no? Uh, uh, is okay, but it's not it's not addressing the problem of the clinical scenario. So doesn't mean, okay, doesn't look the option. Okay, hemoglobin Is the patient having anemia? Is the patient having bleeding? No, so it's not pertinent. Urinary output. Is convenient to monitor the urinary output in this patient receiving diuretic? Yes.
Yes.
So I think that blood pressure and urinary output of the options given in this question, as I always say, you need to dance with the music that is playing the orchestra. Yeah. So with the music that are playing those guys here in this ATI question, the best option obviously should be blood pressure and urinary output, because the other are not pertinent for the monitorization of the heart failure of the client. Suppose that in the Nclex they want to change the question. Instead of urinary output, they could put, for example, intake and output. Then could be the answer. Or maybe they put weight, daily weight. Yes, it's important daily weight. Yes, because it's the best of the best ways of knowing if the person is losing or retaining fluids. Or maybe could put here electrolyte monitorization. Is important? Yes, the patient is receiving furosemide that lowers sodium and potassium, and a part of that is receiving dioxin. So trying to imagine how could be in your NCLEX a similar question like this. Be honest with me. Do you think it's very difficult? The
No.
No.
the
No,
MRU
no.
silence,
No,
the
it's not
MRU
difficult.
silence, the MRU
No, no,
silence. Of course, they're not,
no,
guys.
Pastor.
No, no. I think it's going to benefit you. You know, okay, it is going to benefit you. Okay, so suppose that I put here the blood pressure, and then because the patient is diabetic and I was overthinking, I put a finger stick blood sugar. Okay, let me see what happened. I'm going to submit that. And then of the 5 possible points, I have only 4. Why? Because they want here, instead of this, they want here urinary output. The nurse who wrote this question wanted, she or he wanted to have here in the answer key urinary output. And makes sense, that makes sense that, okay? Because we need to address the heart failure. So I fail 1 point, but I have 4 points. What means that is into my benefit having partial credit? Of course that yes. So is helping this activity for the people that expect taking the test after the end of this month, is helping you to decrease your level of anxiety? MRU silence.
Yes.
Okay, yes. Okay. Vamos a hacer otra. Let's practice another one. Okay. In this case, it's a 74-year-old female client who reports experiencing increased shortness of breath. So, all female with also a respiratory problem. We don't know until now why. Let's see what say the nurse note. This is 1:10, no? 1:10 p.m. 13:10, 1:10 p.m. Okay. Let's see. Let me say that this is 1:10 of today. Today is the 2nd, no? Very well. A and O, it means alert and oriented. I don't think that in Nclex they are going to be using these acronyms, this terminology, because they don't like it. But it's good to know that it means alert and oriented times 3. What times 3? Because it's oriented in person, so I know who I am. Um, in place, I know where I am, and in time. It's a miracle that I know that today is the 2nd of March. Okay, so it is oriented to time. So no problem. No, it's not information. Now say skin cool, clammy, and pale. This is good. Is this good?
No.
No.
No. This is not good. The skin should be warm, dry, and pink. Okay? Makes sense? Or the mucosa. Yeah. Why? Because when you have cool, clammy, and pale skin, it's because the blood is red, no? The blood is warm, no? So when the blood is reaching the skin, I mean, when the circulation is good, then my skin will be warm, will be, ¿cómo se llama? Pink, and will be, ¿cómo se llama? Warm, pink, and dry. Yes? But now this person is sweaty, is sticky, is cool, okay? Is like the skin is too cold and it's pale. So it tells me that the patient is not good. The patient is sick, is significantly sick. And it is happening probably because for compensation, the sympathetic nervous system, the one that works with epinephrine, the one that we call fight or flight system is activated. Why is activated? Because probably this patient is in a predicament. It's a predicament because it's having shortness of breath for a health problem, and because she is seriously ill, she is activating the sympathetic nervous system. That's why probably is having this time of skin. So this is clinical. Do you think it is BS to say that? No. In my experience, in my clinical experience, when you arrive to the bed of a client or you approach a client and then you see that have this kind of skin, immediately your sympathetic nervous system also activate, because you know that this patient is not good. This patient is having a predicament and can make an emergency in any moment. That's why I wanted to comment that. Okay, respirations are labored. I already mentioned what is a labored respiration. It's a respiration where in which you are using your accessory muscle of the respiration, the muscle that you know normally use when you are breathing normally, you know, the muscle of the neck, the muscle of the shoulder, etc. That's why you notice that the respiration is labored, and you know that the frequency is increased, the frequency, okay, and it's shallow. So is having a respiratory problem, a respiratory distress. Why? We don't know. Why? We don't know. And then they say that the patient has crackles, okay? Has crackles. Crackles throughout the both lung fields. So those crackles in the two lungs, okay, probably is liquid. Probably it is liquid, because if it's in two lungs, probably is liquid. The other condition that produce crackles are the infections in the lungs, the pneumonias and the bronchopneumonias, but usually are more in one lung, not usually in both lungs. But well, let's see a little more. Okay, they don't mention a fever, and the patient is not is clammy, is not febrile. Oxygen saturation low, significantly low, no, at on room air at arrival, no. Because I was deciding that this is the arrival. Okay, today at 1. Jugular vein distension. What made me think what is happening when there is jugular vein distension? That the patient has too much liquid, fluid volume excess, no? Fluid volume excess. So probably the patient is in heart failure, but also could be
Right,
in
heart failure.
right heart failure, but also could be in renal failure. If a person doesn't pee, you know what is peeing? Is when you eliminate the excess of water of your body, yes? You eliminate the excess of water of your body, you pee, yes? Now the person doesn't pee and is not in dialysis. Do you think that this person could have a neck vein distension?
Yes.
Yes, because it's retaining the liquid. It's too much liquid in the circulation. Also, when a person has a pericarditis, a pericardial effusion, or a cardiac tamponade can have neck vein distension. Okay, so open your mind because there are many causes of neck vein distension, but the most common and the one that looks belongs to this patient is right heart failure, as you said. Yes. Okay. Um, in Nclex, they ask you in which position you place the client to decide if has or not neck vein distension. What is the position?
45 degrees.
45 degrees elevation. It is this
Thank
question
you.
is in Nclex, okay? This question is in Nclex, okay? Because it's the standardized position to evaluate neck vein distension. Okay, heart sounds moderate. I don't know what is moderate. I'm sorry. I don't understand what this nurse wanted to say when this moderate, but regular. So at least when they say regular, I know that the patient doesn't have a arrhythmia, dysrhythmias. With a rate of 98, there's a little elevated that supports the activation of the sympathetic nervous system. The blood pressure is not significant, nothing important, and the temperature is normal. It goes against a diagnosis of pneumonia or bronchopneumonia and supports the diagnosis of heart failure, of excess of liquid in the circulation and the lungs. Denies pain. Let's see medical history. That is the other information that they give us here. So it has a lot. So medical history. It is confusing because it looks that the medical history was made at 10. If it is at 10, is 10 of the morning. So help me with that. This is 1 p.m. 13:10 is 1:10 p.m. And this is 10 a.m. 10 a.m. Yes. So it looks like this documentation should be first and this second because this is first 10 a.m. previous history.
Maybe it's a
At the
patient that
admission.
went into the emergency, and then the nurse note is the nurse that from the floor.
It is possible. So maybe this is the it looks like it's previous, no? It is previous. And this is posterior. So this is 10 a.m. This is 1:10 p.m. Okay? For me, it's confusing, but it should say the date, no? Okay, so let's see what says earlier. What says earlier, okay? 74-year-old female who is obese admitted with increased weight gain of 4.5 kilo, 10 pounds over the past 4 days. So is this supporting fluid retention? Yes, it is supporting fluid retention. I'm going to make a Nclex question. How many milliliters, mils, ml, milliliters of liquid is retaining this person in these 4 days? How many milliliters? MRU silence. And you're doing
Can you
calculation.
repeat the question?
Ok, ok, ¿cómo hago yo para escribir aquí para que este muchacho vea? Just a moment, let me see if I can at least open a Word document to alternate. This is an English question, okay? The scenario says that the patient, okay, gained 10 pounds, 10 pounds, 10 pounds, okay? You know, 10 pounds in 4 days. which is equivalent 4.5 kilos. And I'm asking you, put in this box, this is an Nclex question, how many milliliters this patient of liquid, this patient retained?
We have to do conversion.
Okay, do the conversion. Put here, it is an Nclex. This is the Nclex. They say the patient gained 10 pounds, which is the same as 4.5 kilos in 4 days. I want to know how many milliliters of liquid is this pain is the patient retaining, gaining, adding to her body in these 4 days. But the silence, no idea. Okay, you need to learn this. Please learn this. Pay attention, because I'm pretty sure that had been said before and maybe you didn't pay attention. Okay, 1 liter of water, of liquid, weighs 1 kilo. If you take a bottle of 1 liter, 1 little, and you put that in the balance in the way that you use to weigh yourself in the bathroom to see that you are gaining weight in the is going to weigh 1 kilo. So you need to know these equivalents. So if this person gained 4.5 kilo, the person gained 4.5 liters. Are you good until now? Yes or not?
Yes.
Yes.
Okay. And you know that 1 liter contains equal 1,000 milliliters, because you need to know these equivalents. That 1 liter is 1,000 milliliters. Yes. So the question in English, how many milliliters this patient gain of liquid? How many milliliters of liquid this patient gain?
4,500.
4,500.
4,500 milliliters. This question is like, what is the color of the white horse of Napoleon? Okay. I can assure you that I know that similar question like this is in Nclex, and you don't need a calculator, okay, to calculate that. Are we good? Okay. Okay.
Yes.
So everybody learned that. Okay. So you need to know those equivalents. Okay. I'm going to ask another Nclex question. My grandson, okay, visited me recently, and his diaper, he has 6 months, 7 months, and I changed him 6 diapers along the day. Okay, the diaper that he is using weighs, let's see, 20 grams. 20 grams. And then the first diaper that I put on him, I removed the diaper and was weighing 15 grams. The second diaper, when I removed it, was weighing 45 grams. The third diaper was weighing 35 grams. The fourth diaper was weighing 60 grams. The fifth diaper was weighing 40 grams. And the sixth diaper in the day was weighing 50 grams. How many milliliters of urine peed my grandson during the day?
130.
Okay, so let's see. So 30, 45, that's 20, 25, 15, 40, 20, and 30. Okay. 10, llevo 1, 4, 5, 6, 7, 7, 11, 11 y 13, 13 y 3 es 16. 160 milliliters. What means that? The dry diaper, okay, weighs 20 grams. So when I remove the first diaper and was weighing 50, it because the difference, which is 30 grams of urine was added to the diaper. That's why I'm subtracting 20, the weight of the dry diaper to each wet diaper that I remove. And I know that if 1 liter of water weighs 1 kilo, 1 milliliter, okay, which is 1,000 of 1 liter, weighs 1 gram, which is 1,000 of 1 kilo. This is the other equivalence that you need to know for this. So because it is 30 grams, it is saying as milliliter. So I can't calculate the urinary output of a baby, a diaper baby, weighing the diapers and knowing need to be given. Is this the way of the dry diaper must be given by the question, yes? But you can calculate how many milliliters peed or had of urinary output a baby just weighing the diapers, okay, of the child. And this is another Nclex question. Okay, so you need to add all this stuff. It's clear, is understood.
Yes.
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 Professor.
Okay, learn these two calculations because it's frequently in Nclex because it's basic knowledge for Nclex, okay? Basic knowledge for Nclex. Frequently tested in Nclex. If you know how to calculate the input and the output and have an idea of how much liquid is retaining a client, okay? So we were in that, okay. So I like to stop in content that I sing in Nclex, and that I know that it's important that you know that, because if you fail these basic concepts in Nclex, you lose a lot of points, and it becomes a little difficult to pass the test. Okay, if you don't answer correctly a question like the one that I asked to you. The diet has consisted, so it's retaining fluid. Okay, so this explains the heart failure of the patient. The diet has consisted of canned soup and cold meat sandwiches. So what is the problem with this diet? Too much sodium, yes? Canned soup and cold meat. Cold meat is ham, mortadella, prosciutto, pepperoni, todas esas cosas. Okay. Denies shortness of breath at rest. So it is the past because it is earlier, no? It is earlier. See? Yes? So she in the past denied shortness of breath at the rest. Dyspnea on exertion. What means that the patient while resting is okay, but then has Dyspnea on exertion, that when the patient is walking, when the patient is climbing stairs, is doing exercise, the dyspnea appears. So it's an exertional dyspnea. This is what means, okay, dyspnea on exertion. Yes, very good. Respiration is slightly labored earlier, 22 per minute. When the nurse saw the client later at 1 was worse, no? ¿Cuánto era? Respiration? Rate, no. If there is no respiration, yes, here is 30 per minute. But earlier, it is 130. Earlier at 10 a.m. was only 22. So this patient deteriorated from 10 a.m. to 1:30 p.m. Yes, deteriorated, no? Okay. Oxygen saturation at 95% on room air. When the nurse saw the client, the client had 88. 88. So deterioration. Few fine rails auscultated bilateral basis. When the nurse saw the client at 1:30, it was a lot of crackles, no? A lot of crackles, okay? Coarse or crackles throughout bilateral long fields. So another sign of deterioration. Heart sounds moderate and regular 3+ pitting edema. So is having a fluid retention. So this client has both right and left heart failure, no? Have both right and left heart failure. Present bilateral lower extremities. Skin cool, dry, and intact. Okay, was a little better before. Abdomen distended, denied discomfort on palpation, alert and orienting time 3, perla. Pupil equals round, reactive to light and accommodation. Past medical history, hypertension for 20 years that is controlled with medication. Coronary artery disease, left ventricular hypertrophy, and right side heart failure. Chronic obstructive pulmonary disease. The patient has history of smoking 2 packs of cigarettes a day. So this patient have left heart failure secondary to a chronic hypertension of many years and has right heart failure probably secondary to the COPD, a cor pulmonale, and is a heavy smoker. Current medications, losartan, hydrochlorothiazide. Which family of medication is losartan, and for what is this medication?
OBS, the Sultan.
Is an ARB, ARB, angiotensin receptor blockers, losartan, valsartan, ibersartan, okay, are ARBs. Those are vasodilators, very similar to the ACE inhibitors, the PRIL group. The big difference is that losartan doesn't produce cough, while the ACE inhibitor can produce in some individual cough. But there is no big difference in the characteristic of both groups. Hydrochlorothiazide is a thiazide diuretic, okay? Okay, so we assume that this medication is given mainly for the control of the blood pressure. The dose of losartan 50, hydrochlorothiazide 12.5. Okay, aspirin 81 milligrams per daily, probably as antiplatelet aggregation because the patient maybe has increased risk for coronary artery disease. Nitroglycerin, so if chest pain, it says that the patient probably has a history of angina and coronary artery disease. So this is what we have of this patient. So let's see which diagnosis is more pertinent to this client. We have worsening or deterioration of congestive heart failure, pneumothorax. This is not a clinical of pneumothorax. Pneumonia, has no fever, has no evidence of infection. Exacerbation of the COPD. They don't describe wheezing. They don't describe that. So the most probable diagnosis, which one you think it is? Do you agree with me that the most probable is worsening or decompensation of heart failure? So let's choose this. So now let's see what is an action pertinent in a patient. It's very similar to the previous case to do. So do we elevate the head of the bed? Yes. So we have apply oxygen 6 liters per minute. We have a decline what has been eating in the last 24 hours. This is not pertinent. This is not useful in this moment. Apply oxygen at 2 liters per minute. Recommend smoking cessation program for the client. So asking what she ate is nonsense. Elevation of the head of the bed is pertinent because the patient has a deterioration of the heart failure. Okay, but now we have oxygen 6 liters, oxygen 2 liters, and teaching a smoking cessation. Which one is the of these three is the best to choose?
Oxygen 2 liters
Oxygen
And
2
why not
liters.
and why not 6 liters?
because he has
Because
a
the
A
patient
COPD.
has
COPD.
COPD.
She is a COPD. That's why they put this trap. So I'm going to choose this because later, when the patient is breathing better, is when I have time and the patient has the capacity of paying attention, is the moment of teaching about smoking cessation. Not in this moment. It's better to give oxygen and elevate the head of the bed are the best intervention. Let's see what we can monitor. It's good to monitor oxygen saturation, yes. Arterial blood gases, yes. Which one is better for this patient, the O2 saturation or the ABGs? What do you think? What is your opinion?
ABG.
Oxygen saturation.
Okay, let's explain you something so you understand why the question. The oxygen saturation is a non-invasive method that is monitoring the level of oxygenation along the time. What means that? You know how is the saturation now, how it is in half an hour, and how is in the next 6 hours. So it's continuous. You understand? The ABGs, you pierce, you introduce the needle in the artery, you draw the blood, and you have the oxygen level in this moment. But you don't monitor, you don't are monitorization. You don't monitor how is the oxygen in 5 minutes, in 10 minutes, in 2 hours, in 3 hours, because then you need to go again and pierce the artery. You cannot be piercing, you cannot obtaining a specimen of arterial blood every 5 minutes unless the client has an arterial catheter, but this client has not an arterial catheter. Entonces, it's better the oxygen saturation because the oxygen saturation allows the monitorization of the O2 saturation and the oxygenation of the client in a continuous mode, in a ongoing way. So if I need to choose between two, I suggest favoring O2 saturation for the reason that I explained. If you didn't understand my explanation, ask me, okay? So O2 saturation is pertinent, is good from my point of view. White blood cell count. Has the patient an infection? No. White blood cell count. Temperature. Has the patient an infection? No. Why temperature? Respiratory rate? Yes, because, the patient has a respiratory problem. So it's the first way of solving, okay, this clinical scenario, okay? The only thing that I can, add question, if it is word, I can complicate the question, for example, with question like the one that I made, etc., and then it's going to make a little more complex, okay? Clinical case with 6 different items tested. And this is the way, but at the end, the clinical scenarios are going to be very similar to those bow tie examples that is presenting to us ATI. And the only thing that you are going to have more questions. You are going to have, instead of this easy movement of stuff here, you are going to have 1, 2, 3, 4, 5, 6 questions that you need to answer correct or not. And you can have 6 or 0 points. You can have 5, you can have 4, 3, 2, 1, or 0 in each one of those clinical scenarios. You can have a partial credit. Do you think that practicing this question is helping? Do you want to continue?
Yes,
Yes.
good.
Yes.
Okay, let's see another.
Professor,
Yes.
good evening. It's Dalir.
Hola.
Well, so far, thank you. All your intervention has been really great. But I don't know if it's right now the best moment to ask you for this, but it will be quick. It was about your a part of your intervention when you say that a liter is equally to 1 kilograms, and
Yes.
you put an example with diapers, baby diapers.
Yes.
So my question is, because
But baby
I
diapers
remember
is in grams and milliliters, okay? Grams and
ex,
milliliters because it's equivalent.
exactly.
Yeah,
So I
go ahead.
remember I saw something similar in a video training or something like that back in the last semester with women who are pregnant and have placenta previa. So a way to calculate how much they are bleeding is weighing their
The pad, the
the
pad.
pads.
So
So
you
it's the
weigh
same.
the
It's the same
dry
principle.
pad, weigh the dry pad, and then
Uh-huh.
weighs the soaked in blood pad, and then it could be equivalent, could be similar. Even if it's blood that is a little bit thicker, we still can use the same rule than
So we
urine.
apply the same principle
Yes,
here.
like the same rule, the same equivalence, that
Excellent.
1 gram is 1 milliliter. So if the dry pad is 20 grams and the soak pad is 100 grams, then the woman bled 80 milliliters of blood, you know? So applies the same. But in my experience, the most common question in English is an old person, an adult person, is gaining weight from one day to the next, or in 2 days, or in 3 days, and you need to calculate how much liquid is retaining, or calculating the urinary output of babies. I think those questions very repetitive in English, and you apply the same rule, the same equivalences that I made.
Excellent.
Very
Thank
good.
you, Professor, for letting me know.
Thank you. Okay. Let's see this question. A nurse is caring for a client who is being admitted to the medical surgical unit from the emergency department. The nurse is reviewing the client medical record. Let's see what we find. Hemoglobin A1C 8.4. So this client is diabetic and is not well controlled. Blood glucose 235. We confirm our assumption. Until now, this patient is diabetic and is not well controlled. Hemoglobin is okay, hematocrit is okay, white blood cell is okay. HDL, LDL are acceptable. This is cholesterol. This is not very important. BNP is okay, it's not in heart failure. Chest rate is okay. Urine, clear amber 5.8, it's the same as before. No. Here there is a mistake of the nurse who wrote this question. You cannot have this 0 glucose with 235 milligrams of glucose. You need to have a little glucose in the urine, but nobody's perfect, okay? But it's okay. There is no problem in the urine, okay? There is no problem in the urine. Okay, what else we have? Administration, medication administration record. Glargine, it is insulin, no? Insulin glargine, long acting. U100. Okay, what means U100? What means this?
Unit.
Okay, when you can have in a vial of insulin, you can have in a vial of insulin. This is a vial of insulin. This is another vial of insulin. And this is another vial of insulin. You can have U100. You can have U25. You can have U500. What means this U? It is an Nclex question, okay? What means this U100, U25, U500? And this is Nclex
Just a
question.
number. Just a number of insulin units that per milliliter in that.
Okay, this is the answer. This means how many units of insulin is present in each milliliter. It means that 1 milliliter of this concentration has 100. It means that 1 milliliter has only 25 units. And this means that 1 milliliter has 500 units. This is super important to know, because if the nurse doesn't know that in for A, B, or C reason the pharmacy is sending a different concentration, you can kill a person that it has order of you 100, okay, 30 unit, and then you draw the insulin from a vial you 500 with a syringe of 100, of you 100, you draw what you think is 30 units, and then this is going to be like 5 times, okay, 30, and it is going to be a too much dose. So you need to know. And the question is very simple. What means you 100? And the answer is 1 milliliter has 100 units of insulin. This is the answer. Remember that each one of these concentration of insulin, you need to find the syringe that is adequate for the concentration. So you are going to have in the syringe, in the insulin syringe, that says U100 or says U500, etc. And 99% of the insulin that you manage in the hospital are U100, but you can have, because it's needed, a more diluted or a more concentrated form of insulin. It exists, and it's important that the nurse knows that this different concentration exists, because if for any reason you are dealing with a different concentration, you need to ask if you don't know how for the adequate syringe for that. And this is Nclex question. Why it is Nclex question? Because if we give too much insulin to a client, we can kill the client. Yes, and it can happen if you ignore this detail. That's why it's Nclex question. In Nclex, it's about the safety of the client. So from the concentration U100, the client has ordered 25 units at bedtime every day. Finger stick random blood glucose before breakfast and bedtime. So twice daily, before breakfast and before bedtime, the doctors order a capillary blood sugar, an acute check. And then you are going to administer insulin, regular insulin, okay, through by this sliding scale. So this is a sliding scale, okay? This is the sliding scale that the doctors order. So when the nurse did the acute check of this client and obtained 235, how many units of insulin need to administer to the client?
3 units.
3 units, because 235 is in this range, okay? Those are practical questions in Nclex, okay? That if you know how to use the sliding scale. Very good. Nclex is straightforward. It's entry-level basic test. It's not rocket science. The problem is that sometimes we have, gaps in our knowledge that could, make us being confused in the exam, okay? Very good. The other medication that is receiving, this is a mistake of the nurse who wrote this question. She or he should write spironolactone. This is spironolactone. So what is a spironolactone? A potassium sparing diuretic. Brand name, commercial name, aldactone, but the correct is spironolactone. Yes, has dioxin, another patient taking dioxin, and has carvedilol, another patient taking carvedilol. We already, okay. Let's see the vital signs. Blood pressure, okay. Temperature, okay. Heart rate, okay. Respiration, okay. So it looks that the main problem of this patient is diabetes, no? Is diabetes with high blood sugar. Okay. Okay. Let's see nurse note. Client received to emergency department from home via private vehicle. Reports fatigue, blurred vision, dizziness, and headache for 2 days. Time 2 days. Reports running out of blood glucose strip and humulin regular insulin due to lack of financial means. States that they are afraid of possible fall from fatigue and dizziness. Live at home alone. Orders received will increase glargine from 20 to 25 units at bedtime. Other meds taken at home remain at the same time. So this is the idea that we have until now. So let's choose of these 4 diagnoses, which is the most adequate to this client that is arriving for our care. Anemia, she has no anemia. Type 1 diabetes, probably because, she's receiving insulin. So it's a diabetes. Possibly could be type 1 diabetes. Heart failure, no, the BNP is normal. She has no symptoms of heart failure. Urinary tract infection, no, the urine exam was normal, no. We saw a urine exam that was normal, no. Yes, was normal. So it is easy. Type 1 diabetes mellitus. Okay, what we should do with the type 1 diabetes. Elevate the head of the bed is not necessary. Teach the client about signs of hyperglycemia could be pertinent, okay? Let's see the other. Low sodium diet, not necessarily is addressing the problem of diabetes. Assess the client feed for sensation, yes, because the diabetes. Encourage the client with a diet that includes iron-rich food, no, because she has no anemia. So the best option here is teach, of the options given, teach the client about the signs of hyperglycemia and assess the fit for sensation. Makes sense, no? You agree? If you don't agree, you discuss with me, no problem, no problem. So let's see, parameter to monitor. Urinary output could be, because in diabetes, we have polyuria. Blood pressure, the blood pressure is okay, it's not necessary. White blood cell count, she's not infected. Fingertip blood glucose, of course, we need to monitor the glucose. Hemoglobin levels, she has no anemia, so urinary output is the best option. Do you agree?
Yes.
Yes.
Okay.
Yes.
So can we survive with this kind of question if until now is the way that ATI is presenting? Yes. And ATI have a very bad fame, no? It's been very, very tricky and confusing. When you have the other type of question, the trends or the clinical scenario, the clinical case, okay, the case studies, you are going to see that the scenario is the same. But then they are going to give you 6 different questions related for that. And I've been mimicking that with those clinical, because when I asking those questions that I ask you, just ask you, okay, what means 100, you 100, what means how many milliliters, is the way that they make questions, 6 questions of the clinical scenario, exploring your knowledge and your clinical judgment. You understand? A nurse is in the emergency department is caring for a client who is experiencing chest pain. This is chest pain. Chest pain. They don't say the age of the client or the gender. And then I have physical examination at 9. Client admitted with report of chest pain radiating to the left arm, sweating, shortness of breath, and epigastric discomfort. It sounds like a ischemic heart disease, no? Sounds like angina, no? Pain of the heart, no? Client awake, alert, and oriented time 3. Lungs sounds clear bilaterally. S1, S2 heart sounds noted. So it's alive. S1, S2, locked up, okay. All pulses palpable. Skin cool, no good. So this is activation of the sympathetic nervous system and diaphoretic to touch. Diaphoretic means sweating a lot, which is a characteristic of the ischemic chest pain. Rates pain 6 on 10. So is moderate to severe. Pain described as sharp. This is not classical of ischemic pain to be sharp. Maybe it's to confuse us. Sharp in the chest area with feeling of tightness. It is compatible with ischemic heart disease and indigestion. Frequently, the patient complains at indigestion when they have angina. Bowel sounds active for quadrant. Okay, we can survive with that. Diagnostic results. Electrocardiogram, sinus tachycardia with ST elevation. So now I think that we have a diagnosis. We have a diagnosis with a STEMI, ST elevation myocardial infarction, because we have probably, okay, an STEMI. So it supports the initial idea of what we suspected, that a myocardial infarction. Blood glucose is okay, white blood cell is okay, platelets are okay, troponin T 0.7 less than 0.1 elevated. It confirms that is necrosis, death of myocardial cells. Troponin I also is elevated. Okay, so we have a acute myocardial infarction, an ST elevation myocardial infarction. Let's see vital sign. Blood pressure, a elevation of the blood pressure, but the patient is having a sympathetic activation, okay? But there is an elevation of blood pressure, but it's not very critical. Pulse 120 is obviously there is an activity, elevation of the sympathetic activity. Respiration 18, so it's not having dyspnea. Temperature is okay, O2 saturation is low. This O2 saturation is low. It's strange. This is a failure by the nurse who wrote this question that give this respiratory rate in a patient that have 88 O2 saturation. But nobody's perfect. Okay. Medical history: hypertension, smoker, 1 pack per day, coronary artery disease, obesity, erectile dysfunction. Notice that they are introducing an element that you should be suspecting something important here. Patient is a male with erectile dysfunction and is having a myocardial infarction. Note, 18 gauge IV inserted in right forearm, infusing normal saline, 100 per hour. Why so much? Continuous monitoring, EKG monitorization, so a monitor indicating sinus tachycardia with ST elevation, provider notified. Medication administration record, sildenafil. What is this? Viagra. Is this important? Yes, because the patient cannot receive what? Nitroglycerin. So this is something that all we need to know, that if the patient that is having the angina or myocardial infarction is taking sildenafil daily, cannot receive nitroglycerin, no nitrosublingual, because can produce a severe hypotension. That's why they mentioned the erectile dysfunction and sildenafil. Simvastatin, this is an statin that is frequently prescribed for people with high cholesterol and ischemic heart disease. Metoprolol, which is adequate, okay, for people with ischemic heart disease, multivitamins. Okay, so let's see what is the most important diagnosis here. Cardiogenic shock? No, it's not in shock. Ischemic stroke? No, it's not having a stroke. Chronic stable angina? No, this is a myocardial infarction. Do you agree, no? It's a myocardial infarction
Yes.
without doubt. Okay, let's see what is an action that we need to take. Do you think that this patient needs, oxygen?
Yes.
Remember that is having O2 saturation low.
Yes, yes.
So the protocol says that if the patient with myocardial infarction has less than 95% O2 saturation, should be placed oxygen. If the patient has 95 or more, no oxygen. If the patient has less than 95, 94 and less, yes, oxygen. And you need to know that. Giving oxygen unnecessarily in acute myocardial infarction has demonstrated that increases mortality or the patient dies. So it's not good give oxygen to clients that don't need the oxygen. So if the O2 saturation is 95 or more, no oxygen in my MI. If the client has 94 or less, yes, oxygen. This patient has 88, so yes, oxygen. Requested prescription of morphine, yes, let's see. Verapamil, no. Calcium channel blockers are contraindicated in myocardial infarction because increase mortality. Prescription of aspirin, 325 milligrams. The administration of aspirin in acute myocardial infarction has demonstrated decreased mortality. Administration of transdermal nitroglycerin. Do you give nitroglycerin to this patient? No. Why? Because it's taking sildenafil. So do you have the same conflict that I have? That I know that this patient needs oxygen. It's important. It can decrease the size of the MI because it's having hypoxemia and as a consequence, tissue hypoxia. But I know that the patient needs aspirin, but the patient also is having pain and cannot receive nitroglycerin. So this patient should receive morphine. The only thing needs morphine. 6 milligrams is an adequate dose. The usual dose of morphine is between 2 to 10 milligrams IV. IV in bolus, but the slow bolus, no? And aspirin, okay, is necessary. The dose of 325 is the usual. So now ATI is doing something that I see frequently in ATI, and is one of the reasons of that I sometimes I argue with ATI that is giving two possible answers. Okay, so they are asking me to choose between morphine and aspirin, and I think that both should be given. So we are in a predicament. A ver, if it were you, which one do you think is the one that you would choose in the test? If you were in the test, I'm pretty sure I can bet, no more $1, but I can bet that the Nclex.
For the pain,
What you will giving? Morphine. Okay,
I'll take
morphine.
let's put morphine. Let's put morphine. Okay, but I'm concerned
because morphine, besides to help for the pain, it's also gonna help us vasodilate.
Correct. I agree. But also the statistics say that the aspirin given in acute MI decreases mortality. So it's important to give the aspirin. And also it's important to give the oxygen if the O2 saturation is less than 95. This is what the protocols of myocardial infarction that the expert says of the management of that. Why the nurse who wrote this question makes me choose between morphine and aspirin when both should be given, I don't know. Okay, so let's see to monitor. Parameter to monitor. EKG rhythm, yes. Need to have continuous monitorization because remember, those patients complicate with cardiac dysrhythmia, ventricular dysrhythmia. Vital signs important, platelets not important, white blood cells not important, glucose is not important, vital sign could be the others, okay? Let's see what is the opinion of the nurse. So the nurse is giving us 4 points. Is giving that we have one mistake. Okay, the nurse should administer oxygen to the client at 2 liters per minute via nasal cannula, and request a prescription for aspirin 325 because the client is likely experiencing a myocardial infarction. So the nurse who wrote this question has her or his personal opinion that the patient doesn't need morphine and the patient just needs the aspirin. I agree that the patient need the aspirin, but the patient also need the morphine. So it is a possibility that this question has a low quality. Yes, it happens in Nclex. I promise you that you will not see this kind of mistakes in Nclex. Nclex review and double review by experts the questions, and even before grading the question, they put the question in those 15 questions that are not graded to see how people behave before the question. So it will not happen in your English. Can you live? Can you survive having all the commercial practice preparation for English? This kind of mistake? Yes, I see that in your world. I see mistake in your world. I see mistake in Kaplan. I see mistake in, ¿cómo se llama? In ATI, etc. Can we survive with that? Yes, because for one mistake, they have 100 of good questions. You understand? But this is a mistake. They cannot make ignore that the patient needs morphine because it's in the protocol, especially this patient that is having pain 6/10 and is not receiving nitroglycerin because it's contraindicated. They say that when hypoxemia is present, oxygen is prescribed to maintain the arterial oil saturation at 90 or greater. Aspirin therapy inhibits platelet aggregation and vasoconstriction, decreasing the likelihood of thrombosis. The nurse must monitor the client EKG rhythm. Eso está bien. Dysrhythmia is the leading cause of pre-hospital death in client, pre-hospital and intra-hospital. In clients who have acute coronary syndrome. The nurse should also monitor the client's vital signs to ensure there is no complication as a cardiogenic shock. So you need to learn when you are using any commercial program to practice question that from time you can find you will have disagreement with the program, okay, like in this situation. But it doesn't mean that those questions are very good and we are having a very good time practicing those questions and we are learning a lot. Yes or not? Okay. This is like the boyfriends and the girlfriends. Are they perfect? No.
No.
They have virtues and defects. Okay. When you find that the virtues are more than defects, you attach to this person. The same as this program. I found that it's very useful. I've been practicing, ATI all my life, since from many years. I found ATI very useful, but from time to time I fight. I argue with the test. And I know for you it's very frustrating because if you are in this situation in a class and then you lost this point, I know this is frustrating for you, but you can survive with that. Don't commit suicide for that, okay? Don't commit suicide for that. Okay, let's see. Okay, another question. Let's see, what is this question? Another emergency question. Okay.
Excuse me, Professor. Can you make it bigger?
It's difficult because then it disappears. I can do that bigger. Let's see.
Thank you.
The problem is that sometimes some questions are too wide, and then okay. So you see, this question is too wide, but let's find another question that is narrower. Okay, this is narrower. A nurse in an emergency department is caring for a client. Client is admitted to emergency department with periodic episodes of wheezing and shortness of breath. Client reports wheezing, chest tightness, and persistent dry cough that increases at night. It sounds like asthma, no? Sounds like asthma.
Yes.
Bilateral
Yes.
breath sound with inspiratory and expiratory wheezing. Color pale, skin warm and dry. Until now, it sounds like asthma. Yeah, one of the diagnoses is asthma. Let's continue the information. Vital sign, temperature, okay, is not infected. Blood pressure is okay. Pulse tachycardia because, activation of the sympathetic nervous system. Respiratory rate increase because the patient is having an asthma attack. Pulse oximeter 90%. So it's not good, but it's not critical on room air. In medical history, is a non-smoker and has history of GERD, gastroesophageal reflux disease. But this is not the symptom of GERD this moment, even if GERD can exacerbate asthma at night because, okay, triggering bronchospasm. So let's discard COPD, pneumonia, pulmonary edema, asthma. What we do with patients with asthma, request a prescription of diuretic. Why? Plan to administer bronchodilator. Yes. Albuterol. Yes. Albuterol. This decline personally breathing. Let's see what else. I mean antibiotic, not because there is an infection. Measure the client's peak airflow. Okay, what do you think is better? The peak flow or teaching personal respiration to this client?
The peak flow.
The peak flow, because it's going to give me the severity of the asthma. This is the adequate. The personal respiration is more for patients with COPD. Okay, what we are going to monitor? Temperature? No. Weight? No. Pulmonary function test could be. Urinary output? No. O2 saturation? Yes. So obviously pulmonary test, O2 saturation. So no problem with this. No discussion with this question. This question is straightforward. No problem. Okay. No problem with that. We got our 5 points. Okay. No problem. Let me see if I have other area. No, siguen la emergencia. A nurse in the ER, emergency department, is caring for the client. So nurse note, client admitted to the ER with a 2 days history of lethargy. The brain is no good. Nausea, vomiting, anorexia, headache, and generalized muscle aches. The client reports diarrhea, abdominal pain, and sore throat. We don't know the age, and is a patient having like a gastroenteritis, abdominal pain, diarrhea, sore throat, in vomits, okay? And now is lethargic, okay? Maybe it's very dehydrated. Those are the, the stuff that you need to start thinking, okay? Pupils are 3 millimeters, equal and reactive to light, intermittent nystagmus, notice nystagmus. Client reports sensitivity to light, photophobia. Client is lethargic, but arouses easily and is oriented to person, place, and time. Hand grasp are strong and equal, so it's not a stroke. Bilateral breath sounds are clear and present throughout. Epical pulse is regular. Heart is okay. Skin is warm and dry. Pinpoint red macular rash noted in upper chest. So a rash in the skin. Pinpoint, petechia. Abdomen is distended. Bowel sounds are present in 4 quadrants. So we are having a patient apparently with something that is affected the brain because the level of consciousness is not adequate. But apart of that, before that, the patient has a history like a gastroenteritis infection, something like this, that is present nausea, vomit, anorexia, headache, muscle aches, and diarrhea, abdominal pain, and sore throat. Like a viral infection or bacterial infection producing this, and then the patient starts having photophobia and having lethargy. Let's see what else we find. Vital sign has fever. So the disease that is affected the brain producing the lethargy and the photophobia is infectious. Okay, it's infectious. And blood pressure, systolic hypertension because activation of sympathetic nervous system, tachycardia, respiration a little increased, O2 saturation is acceptable. The heart, the lungs are okay. My concern is the brain because the lethargy. The organ that looks affected is the brain, okay? And there are symptoms that suggest it has an infection. So of these, we don't have more information. of these 4 possible diagnoses of foreign body in the eye, no. Ulcerative colitis, no. Meningitis and herpes simplex. What is the most probable?
Meningitis.
Meningitis. Okay, so now the scenario is not so easy as the previous, but you can perfectly, in a person that has lethargy, has fever, photophobia, and a previous history of an infection, you can think in meningitis. So what we can do for this client is indicated to initiate seizure precaution, yes.
Yes.
In meningitis, yes. Place the client in contact precaution, no. Meningitis is droplets. Ocular irrigation, why? Flex the client hips, no. Why? Dim the lights in the client's room, yes.
Yes.
Because it has photophobia.
Yes.
Okay. Parameter monitor. Neurological status, of course.
Yes.
Temperature, yes. Eye dryness, no. Bowel sound, not important. Administration, no. Temperature is the most important.
It's an infection.
Yeah, because here's a. Let's see what they think. I think it is the correct, but let's see what they think. Correct. Okay. They agree that this is a scenario you need to suspect. Okay. You need to put this patient in droplets precautions because you don't know the etiology of this meningitis. And you need to prepare the client for lumbar tap. Is the priority at this moment. Why? Because the next priority is initiating antibiotics. The earlier that the antibiotics is initiated, the best the outcomes. But before initiating antibiotics, the specimen of cerebrospinal fluid should be obtained to identify exactly which germ is producing the meningitis, because it's very important, terribly important. So the next priority is, ¿cómo se llama? Prepare the client for lumbar tap. After you initiate, okay, droplet precaution. That's it. Let's see these questions. I'm choosing randomly. Okay. A nurse is caring for a client who is post-operative following a left hip arthroplasty. So it is a hip replacement. Okay. Left hip arthroplasty. Nurse note. Left hip dressing dry and intact. It is okay. 2+ pedal pulse. This is the normal. 2+ pedal pulses present bilaterally is okay. Feet warm, capillary refill quick is okay, no complication. 2 centimeters, 2 centimeter warm reddened area noted in right calf. This is not expected. Why has an area that is red and warm in the calf? Okay, for some of us like me that English is not the first language, this is la pierna, la parte de atrás de la pierna, okay, calf, okay, la pantorrilla. Left calf circumference 31 centimeter, right calf circumference 35. So what is the problem? There is unilateral. Uni is only one side. Lateral, only one side edema in the right side where the calf is tender. What is your thought? What is your thought?
Pulmonary embolism.
Well, but let's see, deep vein thrombosis.
Yeah, DVT.
Deep vein thrombosis. Not yet, until now, okay? Until now, we have not yet, read about this. Now they add, client is diaphoretic, sweating, and appear restless. Guys, when you see somebody restless, the most common cause in the test is low oxygen. Neck veins are distended, and clients report chest pain on inspiration. Now, this is supporting that the clot is moving to the lungs and is a possible pulmonary embolism. Breath sound with fine crackles heard bilaterally at lung bases. Okay, the pulmonary embolism doesn't affect too much the lung sounds. Let's see what else we have. Vital sign, temperature, okay, a little elevated. Can pulmonary embolism, DVT, and thrombophlebitis produce low-grade fever? Yes. So it could be a distractor. Blood pressure is low. Why this patient has low blood pressure? Who can explain me that with words?
Low perfusion.
Why in the aorta, in the branches of the aorta, the blood pressure is low? You know that if the patient, okay, the patient is having a DVT, okay, a DVT, it because it's having a clot in the leg, no? And down a piece of this clot is traveling up, okay, is traveling up through the vein, the inferior vena cava, and is arriving to the right atrium, right ventricle, and then pulmonary artery. The pulmonary artery branches like a tree in many arteries and capillaries that are each time, you know, lower, and then this clot can get stuck here. You know that the blood normally should oxygenate and then transforms in oxygenated blood that return through the pulmonary vein to the left atrium, left ventricle, aorta. And the aorta give one branch to the arm, and you check the blood pressure here. If you have a clot, that is obstructing the circulation of the blood, you notice that part of the blood that should be going from here to here is obstructed. And of course, the amount of blood that is here is decreased. That's why the PE, the pulmonary embolism, a part of producing low oxygen, because the impairment of the gas exchange also produces hypotension and tachycardia. And this is a classical manifestation of pulmonary embolism. So that's why you have this hypotension. This hypotension in this patient is severe. Okay? Is severe. So this patient is moving toward a shock when the blood pressure is very low. In this case, those shocks are called obstructive shock. Los obstructive shocks are produced by the pulmonary embolism, by the cardia tamponade, and the tension pneumothorax that distort the entrance of blood inside the pulmonary circulation and reaching the left heart. This is obstructive shock. So it is compatible with the diagnosis that you made of pulmonary embolism, pulmonary thromboembolism. So the patient is critically ill. So it's not pleural effusion, it's not pneumonia, it's pulmonary embolism. It's not pulmonary edema. What we assess with this patient, oxygen is important, no? And do we plan for antibiotics? No. Thoracentesis? No. Restrict fluids? No. We need to plan for thrombolytic therapy, because being this is a massive pulmonary thromboembolism, is indicated dissolving the clot with thrombolytic therapy. So what we need to monitor, O2 saturation is pertinent, and the patient is going to be an anticoagulant. Coagulation levels need to be monitored. Urinary output is not a priority. Need to be monitored, but no, it's not. But temperature is not. Pain level, no. So coagulation levels, okay. Coagulation test, because the patient need to be anticoagulated. So that's it. Can we, ¿cómo se llama? Survive with these kind of questions in our Nclex? Absolutely yes. So I don't know if you notice that are some practical and vamos a buscar a ver si sale alguna de otra tema. No, este es emergencia también. Well, a nurse is caring for a client who has been admitted to the ER. The client presents to the ER stating that they had a sudden onset of dyspnea while taking a shower. Well, it is also pulmonary embolism, so no, it's repetitive. I'm not going to repeat the same topic. Let me to see if appears other topic. Okay, a nurse in a clinic is caring for a 43-year-old client. Nurse note, client is a first responder who has worked at a large law enforcement agency for 20 years. Client experienced a fire at their home 6 weeks ago that caused significant structural damage and the loss of most personal belongings. Qué horrible. The client and their family were able to exit the home without physical injuries 6 weeks ago. The client reports recent onset of frequent episodes of smelling smoke when no smoke actually exists. These episodes are accompanied by the feeling that my heart is beating out of my chest. Also state they have nightmares, is often irritable, and doesn't want to participate in their usual social activities. They report they have had 2 or 3 episodes where they felt detached from their own body or like they were in a dream, which lasted 5 to 10 minutes. What reminds that flashbacks. The guy is having flashbacks. You know, the guy is living again this traumatic event. Huh? And then is having panic attacks. You know, so what reminds me is a traumatic event, and the guy is living again the traumatic event, and is having during the Bible of these traumatic events, it's called flashback, is having a panic attack, you know, and is mainly affecting during the night, during the sleep. Urine screen, amphetamine negative, barbiturate negative. Well, pensaron que era. This is not drug. This is a PTSD wherever it goes. So we have here a diagnosis of PTSD. Somatic symptom disorder. Somatization is when, for example, you have a test and you have diarrhea. You know, I somatize a lot. I'm a very somatizing person all my life. So when I am stressed, I suffer of neck pain and shoulder, tension. And when I have stress, too much stress, I could have, like a diarrhea. Okay, so it is somatization, somatic symptom disorder. Also, hypochondriasis could be classified as a somatic symptom disorder. OCD, you know what is OCD. And borderline personality disorders are horrible people that are terrible people, very complicated. This is a poor person that is having a post-traumatic stress disorder. Okay, what you can do with a person with PTSD? Is PTSD could be associated with suicidal ideation, yes or not?
No.
Okay, I can tell you that yes. I can tell you that yes. I don't know what ATI think, but the little that I know from mental health, one of the stuff that I know is that those people that come from the war with PTSD, those people that have been victims of gang rape, those people that have been a very traumatic event have a higher incidence of suicide. So
Yes.
I don't know what 80 think, but I read a lot that they are a very high risk of suicide. Okay, so sadly, yes. Schedule the client for assertiveness training. I don't know what is that. Okay, I mean, it's a sertraline. Well, I know the sertraline is an SSRI and is used in that. Naltrexone is for addiction. It is for alcoholism and for opioid addiction. Monitor the use of splitting. Splitting is characteristic of the borderline personality disorder. ¿No está? Aquí. The splitting is something that makes the borderline personality. The splitting means that you are good or you are bad. In the morning, you are good. You are marvelous. Okay. But in the night, you are horrible because I oppose, something that the person wanted to do. This is a splitting. Okay, so it's characteristic of the borderline personality disorder. When you arrive to your shift and you have hospitalized somebody with borderline personality disorder, when you arrive, it's more frequent in women. Okay, don't be upset, but it's more frequent in women. She arrived to you, she approached you, say, "I am so happy you came today to take care of us because you are such a good nurse." Okay, you are a really good nurse. Not like this nurse that is living, that is living now. She's not a good nurse. She's a very bad person because she blah, 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 and tells horrors of this person that is living. But you are wonderful. You are very you have a you have a very you are a very good nurse. But then half an hour later, she asks you, "Nurse, please give me the Percocet because I have pain." And you say, "Okay, no problem." So you go to the chart, you go to the medical administration record, and you find that the nurse who left just 1 hour ago gave the Percocet before leaving. So you tell the client, "Look, the nurse who left already gave you the Percocet, and you have the Percocet every 6 hours. You need to wait a little. I cannot give you the Percocet now. Okay, do you want the Tylenol?" The client tells you, "You are not going to give me the Percocet. You are going to see what I'm going to do." And then the client goes to the room, take a razor, and cut superficially, not very deep, the wrist. And now it's bleeding. Say, "You see, I did that because you." This is the classic borderline personality disorder. Self-mutilate, very emotionally unstable, and is splitting. I just wanted to describe for the person who's in a borderline personality disorder to know, because it's tested. The personality disorders are tested in English. OCD, you know what is an OCD? It has an obsessive idea that frequently is an idea of cleanness and is cleaning and organizing, cleaning, organizing. I like to have an OCD person in my house. Okay, but no, nobody in my house is OCD. And somatic, I already explained what is somatization. The somatic disorders include hypochondria, somatization, etc. And well, and a good for that. So it is a PTSD. So it's not a splitting. Naltrexone is for addiction. The patient is not addicted. Okay, assertiveness training. I don't know for what is that. Maybe it's for OCD. I know what is to be assertive, but assertiveness training. I don't know when they use that. No idea. But sertraline, I know that SSRIs are used in PTSD. All those SSRIs are useful in most of these personality disorders. So let's see what to monitor. ADLs, ability to perform ADLs. I don't think so. A sleep pattern, it could be. Preoccupation for physical manifestation, no, it's a hypochondriasis. Rituality behavior, OCD, impulsivity, it is not. So a sleep pattern is important. Impulsivity,
Impulsivity.
impulsivity. I don't know. I think it's more the borderline personality disorder. Ritualistic disorder behaviors, more the OCD. Preoccupation for physical manifestation, the somatoform disorders. Maybe is this. You know that you need to survive in the test, no? That you need to sometime by using what you know, you need to choose what you don't know. Let's see what they think. Submit. Are we correct? The nurse should administer sertraline and assess for suicidal ideation because the client is most likely expressing PTSD as evidenced by the client's anxiety, nightmares, flashback. Remember, this is another Nclex question. What define PTSD flashbacks? Irritability, social withdrawal, and episodes of depersonalization. The nurse should monitor the client's sleep patterns and ability to perform ADLs because these are manifestations of PTSD that will require intervention by the nurse. Okay, so it is a mental health, okay, example of question. You know, the mental health, at least for me, is a little more subjective, a little more difficult. No? At least for me. I don't know for you. Because maybe I don't like too much this area. Okay, let's do that the last. Okay, it is a pediatric client. A nurse on the pediatric unit is assessing a 6-month-old infant. Nurse note, 6 months is a baby, an infant. Okay, infant is afebrile, moving all extremities well. Why do you bring it? Bounding pulses in bilateral upper extremity. Well, should be no bounding. Bounding is a too strong pulse. In bilateral upper extremities, weak pulses weak femoral pulses bilaterally. Do you know what is the diagnosis? Do you know this diagnosis?
Coarctation of the aorta.
Coarctation of the aorta. Okay, so what is this condition? It is a congenital malformation, okay, where the aorta that has this origin is leaving the left ventricle and make an arc and then descend. The carotid and the upper extremities, okay, the subclavian artery, the upper extremity arteries are okay. But after this part, then the aorta becomes almost interrupted, It's very narrow, okay, it's very narrow. So let me represent that now as a very narrow aorta, and is a very narrow aorta. And as a consequence, you are going to have the arteries, the femoral arteries, the lower extremities are going to have. So here the pulses are strong and bounding. Okay, there is a tendency to have high blood pressure, but here the pulses are decreased. Why? Because the patient is born with this narrowing of the aorta. It's called aortic coarctation of the aorta. Okay, so it is a diagnosis that you make immediately when they say bounding pulses in the upper extremities, but weak pulses in the femoral area. Brisk capillary refill, no work of breathing, abdomen is soft, bowel sound pressing all the time, skin clear. So it's a coarctation of the aorta. Vital sign, temperature okay, heart rate is 6 months, is elevated. Respiration is okay, blood pressure is acceptable. A little high because it will be a little lower. Okay, so it is without a doubt a coarctation of the aorta. It's not a ventricular septal defect, it's not a patent ductus arteriosus, it's not tricuspid area, atresia. This produces murmurs and is not described. The coarctation of the aorta doesn't produce murmur. Okay, what we need to do, prepare the client for mechanical ventilation? No. No intubation, no mechanical ventilation. Anticipate and provide the order for the administration of prostaglandin E1. This is administered when there is patent ductus arteriosus. Okay, you can close, okay, with this stuff, but no, the coarctation of the aorta. Except for manifestation of cyanosis, no, this is acyanotic. Educate the guardians on the need of oxygen therapy, maybe. Anticipate an order of inotropic medication, maybe. So let's see what says ATI. Okay, so no mechanical ventilation. Prostaglandin is not indicated in coarctation of the aorta. Cyanosis, it is acyanotic. So why is necessary oxygen, even if they don't mention that need, or could be because this client could develop left heart failure? What is the problem of the coarctation of the aorta? That the heart need to pump against an aorta that is too narrow. You understand? So it is going to produce dilation of the left ventricle and left heart failure. That's the only explanation that I find, okay, for this question. Let's see the monitor. Dysrhythmia, maybe systemic hypertension, yes. Murmur, no. Heart failure, yes. Hypercyanotic spells, no. Murmur, no. Hypertension, yes. Let's see what they think. Why hypertension? Okay, why hypertension? I'm going to say why hypertension. Here you have two important arteries that irrigate two organs that are very important, that are the kidneys. So you understand that the heart could be enlarged because it's pumping against this narrow aorta and is over a lot of work. It can produce heart failure. But then the narrowing is going to make the blood flow here decrease. That's why in the femoral artery, the pulses are decreased, no? So the kidneys are receiving less blood than normal. As a consequence, they are going to produce renin. When the kidneys that receive less blood, less pressure of blood as they needed to work, they produce renin. The renin activate the angiotensin 2, which elevate the blood pressure and activate the aldosterone, we produce retention of fluid. So this is what happened in that. I think that this pathology in the way that has been tested in this question is too complicated for Nclex. But let's see what they say. Let's submit to see. Okay, partial are correct. What they say, the nurse should anticipate the provider to prescribe inotropic medication and prepare the infant for mechanical ventilation. I don't know why. Oh, as part of the preoperative preparation. Ay, pero in any moment, they told me that it's going to surgery. Okay. Okay, mechanical ventilation, yes, if the patient is going to surgery, okay, it is necessary. Okay, so they don't want oxygen therapy, they want here mechanical ventilation, assuming that the patient is going to surgery. The infant is most likely experiencing coarctation of the aorta according to the physical assessment, finding of bounding pulses. You know that. The nurse should monitor the infant for systemic hypertension and heart failure because the potential complication related to the corrective surgical procedure. So heart failure and systemic hypertension. Why? Because I explained that to you. If the aorta is quartered here, is narrow here, the poor heart need to pump against this narrowing and will dilate, and then you are going to have heart failure. And why hypertension? Because when the kidneys don't receive enough blood, they produce renin. The renin activates angiotensin 2, and this produces hypertension. This is the explanation, okay? So the patient is at the risk of hypertension and is at the risk of heart failure. Of course, this needs surgery, elective surgery, not emergency surgery. It's elective surgery. But they wanted me to educate the parents about the artificial ventilation because the patient is going in the future to surgery. Okay, it's okay. Let's accept that. I prefer to use oxygen, but because they heart failure, no? But they want it is not important. The important that we review a quartation of the aorta. Yeah, we review quartation of the aorta. Do you understand with my explanation quartation of the aorta? Tell me yes or not.
Yes.
Yes.
Okay. Yes. You're so timid. Okay, guys, I'm not going to bother you anymore. This is enough for today. Okay, so see you next time.
Thank you.
Thank you for.
See you.
Okay, thank you.
Thank you for your attention. Bye-bye. Okay, let me
Thank you.
check.